Next topic is diagnosis and management of ascites. I request chairpersons of the talk to please be seated on the dais. Dr. Satvik Saru, Senior Laparoscopic Surgeon of Prayagraj City. Welcome sir. Dr. Harish Srivastav, Senior Physician and Director Mohak Hospital, Prayagraj. Welcome sir. And Dr. Rajendra Dayal, Senior Physician of this Prayagraj City. All the chairpersons, please be seated on the dais, and I welcome now our speaker of the talk, Dr. Sunil Dadich.
First of all, let me take the honor of on behalf of IMA Allahabad branch, I welcome Professor D.K. Nigam sir. He just come, and he has been a teacher of so many teachers also. Presently, he is Professor Emeritus. If I remember correctly, when I was doing my PG in 70s, at that time he came from England after some special training, and he was the first doctor to start endoscopy here in Allahabad. At that time, there was no private hospital in Allahabad. So he was the first person. So, sir, thank you very much. Thank you very much for coming, sir. Now, coming to the topic now, the next speaker is Dr. Sunil Kumar Dadich. He is Senior Professor and Head of Department of Gastroenterology at SN Medical College, Jodhpur. The academic achievement, he did his MBBS, MD from SN Medical College, Jodhpur, and he has, to his credit, more than 50 scientific research publications in both national and international journals, 15 book chapters, been a medical teacher for MD Medicine and DM Gastroenterology students since 2004. He is a Young Investigator Award from ISG during annual conference at Pune, the Best Poster Presentation Award from annual INISL meeting at Mumbai in 1998, Gastroenterology, Endoscopy, Pediatric Gastroenterology Quiz Awards, ISG Travel Fellowship, APDW, Cebu 2006. The Best Oral Presentation Award from PENSA 2017, and Chanaredi Award and Gold Medal in Rajabikon 2005 held at Jodhpur. Best Oral Presentation Award at ICFL, Berlin, Germany 2018, and then Presidential Poster Award at AASLD 2022. Veer Dugadas Rathod Samman by His Highness Maharaja Gaj Singh II of Jodhpur 2016, Times Marwar Healthcare Achievers 2016, and Health Icons of Jodhpur 2023 by Times of India Group, Jodhpur. Dr. Dadich, I will request you to please start your topic. This is a very good, very important, very easy topic. You can say easy to diagnose, difficult to treat. Right from the time when we were PG students, so there were no medical, there were no modalities except the percussion, no dullness and fluid thrillness. There was no other. But now with sonography, it's so easy to diagnose. Even small amounts of ascites can be diagnosed, and a diagnostic aspiration can be done. I think what has been other achievements, Dr. Dadich is going to tell us. Please go ahead, sir.
Thank you, sir. Thank you, Mr. Chairman, for the kind introduction. At the outset, I will thank Dr. Rohit Gupta and Dr. Anuba for giving me this opportunity to talk on this subject. And next 20-25 minutes, I'll be talking to you regarding the ascites, how to manage and how to diagnose it. The word ascites comes from the Greek word ekistos, that means a bag, a bladder or a bag. So ascites means a pathological accumulation of fluid in the bag in the peritoneal cavity. So ascites is a fluid accumulation in the peritoneal cavity. It can be because of many causes. The cirrhosis of liver is the most common cause. These are the Western data. If you come to our Indian data, cirrhosis of liver accounts for 2/3 of cases with ascites. The second commonest cause is tuberculosis. And I would say the third would be the malignancy, pancreatitis and others. So it is in clinical practice, routine our clinical practice, it is very important to differentiate whether this ascites is because of a liver disease, cirrhosis or any other, or it is because of tuberculosis or because of malignancy, and then you think of any other cause, depending upon the clinical setting. Ascites can be because of the normal peritoneum. It can have a fluid in the peritoneal cavity. or it could be a disease of the peritoneum which can cause accumulation of fluid in the peritoneal cavity. With normal peritoneum, it is because of liver which is congested, means anything beyond the liver, a hepatic outflow tract obstruction beyond liver, IVC or heart disease. So you have a heart failure, constrictive pericarditis, a right-sided cardiac disease, a thrombus in the IVC leading to Budd-Chiari syndrome, and the hepatic venous outflow tract disease or the PS disease. Liver disease itself can cause the ascites formation, the commonest one being the liver cirrhosis due to various causes. Apart from liver, even the portal vein occlusion, especially the acute portal vein occlusion, can also cause ascites formation. And there are many other causes of ascites like chylus, like pancreatic bile, and the renal related causes. In patients who have diseased peritoneum, the ascites is mostly because of infection. This could be a bacterial or tubercular, or it is because of malignancies, a peritoneal malignancies, or a pseudomyxoma peritonei, or any other malignancy which can cause ascites. And there could be other uncommon causes of ascites, which includes vasculitis, granulomatous, or eosinophilic. How to evaluate the ascites patient? Most important thing is to take the good history. The history means you have to rule out the liver disease, because the commonest cause is liver disease. So history related with liver disease, you rule out this intake of alcohol, injection, drug abuse, which can cause viral hepatitis, a past history of jaundice, that could be because of an infection in the past in the liver, blood transfusion, acupuncture, tattoos, ear piercing. These all are predisposing factor for chronic liver disease or chronic viral infection in the past, which can cause a liver disease, and the person can come to you with ascites. Malignancies, especially the breast malignancies, gastric stomach malignancies, lung malignancies, or pancreatic malignancies can also cause ascites, and they will have a lump in the abdomen. A history of cardiac and renal disease, again, very important clinically. A common difference between the cardiac disease, nephrotic renal disease, and the liver disease. In cardiac disease, the ascites will be preceded by pedal edema, then they will have ascites. Whereas the renal disease patient will have generalized anasarca first, and they will also have ascites. Whereas a liver disease person will develop the ascites first, and then followed by the pedal edema. So if you analyze the history in detail, you are able to differentiate whether this is a renal origin, or a liver origin, or a cardiac origin. So to summarize, in history you have to rule out the liver-related illnesses, you have to rule out the infection like fever or tuberculosis in the past, history of pancreatitis, thyroid disorders, hypothyroidism, mixed edema can cause ascites, malignancies can cause cardiac disease, and the hematological disorders. Once you take the good history in patients with ascites, you need to examine. And we all are aware of these 5 types. So the fluid should be differentiated from other causes of abdomen distension like platters, like fat, like fetus, or feces, or a fetal growth. You examine the position of umbilicus. Usually in ascites, the umbilicus is horizontally stressed. We call it as a smiling umbilicus. Okay? And ascites can be detected by septic dullness. We all know about it. Puddle sign, it is very important to perform this puddle sign. A very large, small amount of ascites can be detected by abdominal ultrasound. How to perform puddle sign? The person should be kept in knee elbow position. The fluid comes to the bottom part of the anterior wall of the abdomen. There you can tap it, or you can, with the help of stethoscope, you can find out if there is a small amount of fluid in the abdomen or not. Physical examination, you should look for the evidence of liver disease like palmar erythema, spider angiomas, gynecomastias, muscle wasting or sarcopenia. Look for elevated jugular pain pressure in patient with cardiac disease or right-sided cardiac failure, constrictive pericarditis. Enlarged tender liver in patient with alcoholic hepatitis. In Budd-Chiari syndrome also you will have enlarged tender liver. And anasarca, as I told you, it is a feature of a renal disease or a cardiac disease. So these are the spiders. You have a center arteriole and the radiating vessels all around. It's very typically seen in patients who have alcohol-related liver disease. They are commonly located in the upper part of the torso, in the Dadich territory of superior vena cava. The typical sarcopenia of cirrhotics, you will have abdomen which is distended. You can also have pedal edema, but the rest of the body, rest of the muscles are thinned out. The person is severely sarcopenic. The palmar erythema is classical. and you also have neurocognition, especially in patients with alcohol-related liver disease and those who are on drugs like this one. You also look for prominent abdominal veins, and they flow in those veins, in the direction of flow in those veins, range of lymph nodes, anywhere. I mean, especially you look for supraclavicular lymph node, range of splenomegaly. Splenomegaly is a sign qua non of total hypertension. Anybody who has splenomegaly, unless proved otherwise, he should have total hypertension. Nodular liver is cirrhosis, a cystic varicose nodules present over the umbilicus in some patients with abdominal malignancy indicates secondaries in the umbilicus. So these are the prominent veins over the abdomen. You can see these dilated veins, and if you check the flow, this flow is from below upward. The normal situation, the umbilicus is a watershed area. Anything above umbilicus will have, and the blood will flow away from umbilicus always. Means above umbilicus it is away from umbilicus, below umbilicus it is toward the umbilicus. Okay, so if there is any change in the direction of flow and you have a prominent veins, the vague veins are very important in a patient with pulmonary syndrome. So these are very subtle things which you do in clinical examination. You will be able to diagnose a person whether they are having hepatic venous outflow rate obstruction or not. And these vein flow should be detected in a person standing position, not in a supine position. In supine, the vein may collapse. The person is standing, the vein will become more prominent. This is a classical left supraclavicular lymph node enlargement. This is too big, but sometimes they are small. And if you keep the hand in the base of the neck, you will see them, and it is very important to diagnose. And the moment you put the hand, and you have the diagnosis. So similarly, this is the umbilicus, and you have a nodule here at the umbilicus. This is secondary at the umbilicus, the commonest primary being the abdomen, the stomach, and other organs in the abdomen. So to summarize the physical examination, you look for the evidences of liver disease, a cardiac disease. You have to look for the finding of ascites, the septic dullness, what are the signs, splenomegaly, veins, signs of malignancy, cachexia, weight loss, lymphadenopathy, any palpable mass, on the signs of fever or lymph node or any area of pain or tenderness over the abdomen. Once you examine the person, the first thing you do is the paracentesis. You remove the fluid for diagnostic. It could be for diagnostic purpose, it could be for therapeutic purpose. If the person is having tense ascites, you remove the fluid at the same time to diagnose it, and you relieve the person of symptom of abdominal discharge. What is the patient position and the choice of needle in the entry site for doing paracentesis? If the person has large amount of ascites and a thin abdominal wall, it can be performed in supine position, peripherally from the left lower quadrant between umbilicus and the anterior superior iliac spine. A lesser amount of fluid, the person can be tilted on one side, either on right lateral or left lateral decubitus position, and you can tap the fluid from the corner. A minimal fluid should always be tapped under ultrasound guidance. Once you tap the fluid, minimum requirement is to send the fluid for these 3 or 4 tests. This is the bare minimum requirement. You have to send it for cell count, for total protein, and for albumin. This is most important. And sometimes you also include cytology. Rest all tests are optional in a person who have a clinical indicator of pancreatic disease or a liver disease or a biliary ascites. Then you think of these things. Gross appearance of ascitic fluid will tell you what is the origin of fluid. A routine ascitic fluid should be tested, and when you test the routine ascitic fluid for albumin and protein, simultaneously serum albumin should be measured at the same time. I'll tell you the importance of this. So grossly, when you remove the fluid, it could be a transparent, yellow or cloudy, which is seen in cirrhosis, tuberculosis, or in some patient with SPP, spontaneous bacterial peritonitis. If it is a hemorrhagic, it could be a traumatic tap. It could be peritoneal carcinomatosis. Sometimes in tuberculosis also you can have hemorrhagic, or hepatocellular carcinoma, you can also have hemorrhagic ascitic fluid. A milky ascitic fluid is a chylous ascites because of blockage in the lymphatic drainage, a typical milk-like fluid which hydrating state content. A dark brown or blackish fluid can be because of biliary or pancreatic cause. Once you remove the ascitic fluid, examine it grossly and test it for protein, albumin, and cell count, you should calculate the gradient. This is the most important step of ascitic fluid examination, which is calculation of serum albumin ascites gradient. So what is this gradient? This sag is serum albumin minus ascitic fluid albumin. So you subtract this ascitic fluid albumin from the serum albumin, then you will have a value. If this value is more than 1.1, this indicates 97% probability that this ascitic is because of portal hypertension. If this gradient is less than 1.1, there are 97% probability that this ascitic fluid is not because of portal hypertension. You have to look for some other causes. So this will direct you to go in this direction, in liver disease direction, or in non-liver disease direction. There are the list of causes of high-graded ascites, mainly related with liver. The list of causes with low-graded ascites, mainly with biliary, non-hepatic causes, biliary, nephrotic, pancreatic, carcinomatosis, tuberculosis, lymphatic, chylous, and many others. Again, in a person who has got a high SARC, if he also has high protein, high SARC, high protein, means liver is normal. There is something beyond the liver, means something is there in the heart, or prostatic pericarditis, or a early part of pulmonary syndrome, then it can have a high protein. So again, once you have gradient, if the total protein is high or low, you can differentiate whether this fluid is coming from liver or from beyond the liver. So this is how to approach. You calculate the SARC. If it is more than 1.1, high gradient ascites. If the ascitic fluid protein is less than 2.5 gram, then it is definitely from liver origin. If it is the total protein is more than 2.5 gram, then definitely it is because of post-liver causes like the cardiac, like the pericardium, like the urticaria or IVC obstruction. Okay, if it is less than 1.1 or low gradient ascites, then it is non-hepatic causes like biliary, pancreatic, or malignancy or tuberculosis. So in our routine practice, we have either it is because of liver or cardiac or because of tuberculosis and malignancy. So liver and cardiac will have high gradient, tuberculosis and malignancy will have low gradient, and to differentiate between liver and cardiac, you go for total protein. High total protein, it is cardiac, and low total protein, it is liver. Very plain and simple, mathematical. There are many fallacies of this gradient calculations. You may not be. Sometimes when there is a low albumin, hypotension, then it is fallacious. In chylous ascites also it is fallacious. The second important thing is to go for cell count. Cell count, if it is more than 500, then look for what is predominant. If it is lymphocytic predominant, likely to be tubercular, malignant, or other cause. If it is polymorphonuclear count, neutrophil predominant, then it indicates infection. The infection can be primary or secondary. Primary infection is spontaneous bacterial peritonitis, and there is a secondary bacterial peritonitis, or it could be highly pancreatic ascites. If the cell count is less, then it is a PMN predominant, more neutrophils, again indicates infection, less neutrophils, and it indicates a simple unconjugated ascites of cirrhotic origin. How to differentiate between SBP, this is the primary bacterial peritonitis, also called as spontaneous bacterial peritonitis, from secondary bacterial peritonitis. This is monomicrobial, spontaneous or primary. The secondary is always polymicrobial. Proteins are very high, proteins are less. And the glucose and other things may not be able to differentiate. Other tests which can be ordered in patient with ascites are in ascitic fluid. You can go for ADA levels. If it is high, it will favor tuberculosis. Glucose level, if it is low, it will favor infection. LDH level, again, if it is low, it favors infection. Normal LDH level in ascitic fluid is half of the serum LDH level. Normal glucose level of ascitic fluid is same as that of glucose, blood glucose. So this is how to compare what is the normal or abnormal glucose level in the ascitic fluid. Similarly, amylase level in the ascitic fluid. Normally, the ascitic fluid amylase is half of the serum amylase. If it is more, it indicates a pancreatic cause of ascites. Cytology to look for malignancy, triglycerides to confirm that it chylous ascites, bilirubin when you are suspecting a bile leak, and ascites because of biliary leak. Other test which can be ordered in ascitic fluid is culture. In select cases, suppose you are suspecting or you have found a high PMN count, a secondary or primary peritonitis, you send it for culture to look for the bacteria, and for cytology to look for malignancy. What I do in my practice is, initially you send around 102 ml of fluid of ascitic fluid and send it for cytology. If it comes negative, and if you have a strong suspicion of malignancy in that patient, ask the patient, ask your resident to repeat the ascitic fluid tap and ask the person and roll the patient in the bed 5-10 times one side to other side, like right lateral to left lateral, again right lateral to left lateral, and then you tap the fluid, and the minimum amount is around 500 to a liter of fluid, and again send it again for cytology. Probably that will increase the chances of being positive for malignant cells. Other imaging can be done is ultrasound. We all know about it. It can tell you the amount of fluid, the location of fluid, the presence of liver, cirrhosis or not, kidney status, peritoneal deposits, and many other things. This is very important. CT scan also is a further extension. When the sonography you have some doubt, you can go for CT scan to rule out the primary other causes. Laparoscopy is indicated in select cases of ascites, especially when you suspect it is the peritoneal cause of ascites, or when it is a low-graded ascites, when you don't know what is the cause. You usually have a common difference between difficult differentiation between a tubercular or malignancy, and when you do laparoscopy, you can typically see these fibrin bands and the peritoneal deposits. You can take biopsies from that. Fluid can be aspirated under peritoneal endoscopy guidance and can be sent it for examination. Again, tubercular ascites, which is the second most common differential diagnosis in our group of patients. So you tap the fluid, send it for ADA. If it is high, it will favor you. Ascitic fluid AFP, not seen in all the cases, but if it is there, it will favor your diagnosis. Most sensitive test would be a fluid PCR done. If it is positive, it will confirm that the person has got ascites. It is very important to confirm the presence of tuberculosis, because in previous lecture you have heard the ATT-induced liver injury. If you don't confirm the diagnosis, then you will end up with other complications. So, in a ascites patient, first thing is confirm whether they have ascites or not by your physical examination. Second, you do analyze the fluid and divide it into a high gradient or a low gradient, and accordingly you decide how to go further. Ascites again can be graded for clinical practice purposes into grade 1, 2, or mild, moderate, or severe ascites. A recurrent ascites means ascites that recurs at least 3 times within 1 year, despite appropriate treatment, is a recurrent ascites. How to manage? This is the most important. Ascites is not the diagnosis, it is a finding. While managing ascites, your goal should be to find out what is the cause of ascites, alleviate the symptom of fluid accumulation in the body, in the abdomen, and look for any complications of ascites. This is mainly the management of cirrhotic ascites. For a person with liver cirrhosis and ascites, the first step is salt restriction. Recommended salt restriction is less than 2 grams per day, but ideally, in my practice, you go for, this is equivalent to around 4 to 6 grams of salt, common salt. This is sodium. This is sodium less than 2 grams. The common salt is around 4 to 6 grams. So moderate restriction is okay. Let them eat whatever normally, and no added salt diet should be preferred. And salt restriction, if you go for a strict salt restriction, it will reduce the palatability of food. The person may eat less. Water restriction is not required in cirrhotic ascites unless when there is a hyponatremia. Similarly, dietary sodium restriction is not required in a person who do not have ascites but have cirrhosis. Increased salt intake is very important to recognize in practice. Person may be eating the other forms of salt, rock salt, black salt, yellow salt. Sauce, we have a lot of high sodium content. Seafood, packaged food, they all have very high sodium content. The person should be specifically advised not to take these food items. Diuretics is the mainstay of treatment of cirrhotic ascites. We have 2 choices. Either you go for the mineralocorticoids or the loop diuretics. Mineralocorticoids in the liver cirrhosis are the first choice of diuretic therapy because of there is secondary hyperaldosteronism in patients who have liver cirrhosis. So if you counteract the aldosterone, you have to give mineralocorticoid group of diuretics, which will reduce the aldosterone and which will also have a diuretic effect. The only problem with these spironolactone is they are slow acting. So before increasing or decreasing the dose of spironolactone, you have to wait for at least 72 hours before taking any decision to add on loop diuretics or not. So in routine clinical practice, if a person only has ascites, moderate ascites, you start with only mineralocorticoid. If the person has also ascites as well as pedal edema, you can combine spironolactone with a loop diuretic to have a good effect. Again, whenever a person develops infection, hepatic encephalopathy, hypotension, rise in creatinine or AKI, sudden drop in urine output, GI bleed or hyponatremia, you need to stop diuretic. This is very important. So, managing ascites, restrict sodium, use diuretics. Sometimes when there is a French ascites, you can also go for large volume paracentesis. Large volume means removing at least 4 to 6 to 8 liters of fluid at one go. Whenever you do large volume paracentesis, it should always be done under cover of IV albumin therapy. The complications of ascites in cirrhosis can be refractory ascites. When the ascitic fluid cannot be mobilized by the use of diuretics, it cannot be mobilized by the highest dose of diuretic, that is diuretic resistant. Or when the highest dose of diuretic cannot be used because of side effects, then it is diuretic intractable ascites. How to manage refractory ascites? Again, do large volume paracentesis, optimize the diuretic therapy, use another diuretic compound which is midodrine, alpha agonist, or patient can be sent for TIPS therapy, which is a shunt between portal vein and the hepatic vein. It will reduce the portal pressure and reduce the formation of ascites. And anyway, these patients with refractory ascites are the candidates for liver transplantation. Another complication can be infection in the ascitic fluid, which could be spontaneous. Most commonly, you have to diagnose by cell count, increase PMN more than 250, and give them appropriate antibiotics. And STP can be prevented by prophylaxis in certain group of patients. Hepatorenal syndrome is another complication of ascites. When the ascites become refractory or a long-standing or diuretic non-responsive ascites, they can develop AKI, which leads to further complication, and they are managed in a typical way. Other complications could be hyponatremia, diuretic induced or the disease induced, hepatic hydrothorax. They can have a fluid in the right side of the thoracic cavity most commonly, and there could be hernias because of ascites, commonly the umbilical hernias or the inguinal hernias. So, ladies and gentlemen, to summarize, paracentesis and calculation of SAC is the most important thing for the diagnosis of ascites. A high gradient means cardiac or liver causes. A low gradient means non-cardiac, means a primary peritoneal cause. A low gradient means mostly it is a primary peritoneal cause. So a systematic approach is very important. Once you diagnose the person as having liver cirrhosis, ascites, then the salt restriction, diuretic is the most important thing. Refractory ascites, you go for LVP, you go for TIPS. Liver transplant is the treatment of choice. Non-cirrhotic ascites should be based on the underlying cause. Tuberculosis, give them ATT, malignancy, treat the primary malignant disease, or cardiac or renal accordingly can be taken care of. And regularly monitor these patients for infection, especially the spontaneous peritonitis. Thank you very much.
Dr. Dadich, you took this procedure TIPS.
Yes, sir.
How useful is that process? I mean, before going for a liver transplant.
Yes, sir. Sir, the TIPS is a transjugular intrahepatic photosystemic shunt.
Yes.
That means you go from jugular vein, you go through the right heart, the SVC, right heart, IVC, enter into the middle hepatic vein, and from middle hepatic vein you puncture the portal vein. Okay, then you place a stand between hepatic vein and the portal vein. So this is a photosystemic anastomosis or a shunt creation, which is intrahepatic, which is within the liver. Okay, so TIPS is important before liver transplantation, because when you go for liver transplantation, when you remove that liver, the TIPS can also be removed along with the liver, and you have a new liver. Okay, but if you do shunt surgeries prior to transplantation, then you distort the anatomy of the portal system. Then the surgeon will have difficulty in anastomosing vein to vein, the portal vein to portal vein, and the hepatic vein to hepatic vein. But TIPS being intrahepatic, which can be removed along with the explanted liver. So this is important in a person who is awaiting liver transplantation. TIPS has very important role in reducing the portal pressure. So it has a very important role in controlling patients with refractory ascites, in patients who have a refractory variceal bleed. So in any disease which requires sudden reduction in portal pressure, I think TIPS is the choice.
Thank you for increasing our knowledge bank. I am not aware if anybody is doing an Allahabad. Thank you very much, Doctor. Any questions from audience? I already told in the beginning that it's very easy to diagnose.
In a single time, you can, if it is a therapeutic tab, you can, without supplementing albumin, you can take at least 4 liters. If anything beyond 4 liters, then you have to supplement albumin at a dose of 8 gram of albumin per liter of fluid. Okay. Yeah. So commercial preparation of albumin is around 20%, 100 ml. So it is 20 gram in 100 ml. So you calculate accordingly 8 gram per liter of fluid. So that much albumin should be supplemented to prevent the circulatory failure post paracentesis.
The IR people are doing tips, Dr. Dayal.
Right.
They've started doing tips, and they are, recently there was a patient with Budd-Chiari syndrome, and 2 patients, they did a hepatic venography and opened the hepatic veins in IVC in a nice way, and the patient's ascites is controlled very rapidly. So we have good, excellent younger generation who's coming up with very good intervention.
Because repeated paracentesis gives rise to ultimately so many infections and then
Yes.
things. So how useful is this? I mean, what was your result?
So very good results. With Budd-Chiari syndrome, if you open, in Budd-Chiari syndrome, you have the hepatic vein thrombosis and the IV thrombosis. So if you open up the hepatic veins in IVC, the ascites is rapidly controlled.
It's a cure.
Very good.
If you do it in early stage of the disease, if you open up these veins, whichever vein is blocked, either hepatic vein or IVC, then you cure the disease. You reverse this cirrhosis if it has already occurred. So in Budd-Chiari syndrome, there are technical difficulties in performing tips because of blockade of IVC and hepatic vein, because tips is a shunt between hepatic vein and portal vein. If that is blocked, then you cannot make a shunt between these two. So what they do is they do dips. Dips is a direct IVC to portal vein shunt. So the shunt is placed directly between MPV, the main portal vein, and the IVC. So it is another way of type of tips, which is called as tips. It is done in Budd-Chiari.
Pranav.
Thank you, Dr. One question.
Hello. So there is one common dilemma regarding advising patients for salt restriction.
Yes.
So, like, do we tell them to take 4 to 6 grams, or is there any?
No. What is done in routine clinical practice is you ask them to eat whatever is home cooked food. Don't put any salt over and above, and then avoid those high salt containing stuffs which I listed. So ask them to avoid all bakery items, all the pickles and the chutneys and everything. So home cooked food is okay. Don't add salt over and above. And this is called no added salt, right? And then avoid those food items which are packaged. Any sauce or chips or anything. Packaged food should be, because they have a very high content of sodium as a preservative.
Measurement in tablespoon or pinch of salt, anything like that?
The 5 gram is 1 tablespoon. So if you want to really measure it, then ask the cook to prepare a food without putting any salt and give 5 gram salt pudia to the patient, and then ask him wherever you want to put it, he can put it. So 5 gram per day is enough of common salt, table salt. The sodium is 2 gram, but the common salt is 4 to 6 gram.
Thank you, Dr. Dadich, for enlightening us with the recent developments in the management of ascites. Thank you so much.
I request now President Dr. Kamal Singh sir and Organizing Secretary Dr. Rohit Gupta to felicitate our speaker and the chairpersons of the talk.